Hi guys, it's Kathleen. Today I'm going to talk about derm, which is somewhat of a long lecture, but we'll get through this. And derm is really about practice, and it's about looking stuff up. There's a lot to derm, quite a bit, but derm's fun. If you look at it like, I need to look this up, I need to double check, I need to ask, I need to really take a good review of systems and ask what's going on with this patient. Oftentimes it's a lot of fun. You're going to get close to providers, dermatologists that can help you out and that are willing to help you out too. I've spoken to a lot throughout the years, and there are certain things that you have to speak in terms of a dermatologist. They're going to want to know certain things, certain terms, where the rash is anatomically, how long, and some very common things that I'm going to teach you today in this lecture. Where to begin? Derm is a huge subject. The starting place should be describing the lesion adequately. So where to begin? We're going to talk about the morphology, what type of shape or lesion this is. Is this a macule versus a patch, and the difference has to do with size? Is this a papule versus a plaque, and the difference has to do with size? Is this a nodule? Is this a vesicle or a bulla? Again, the difference has to do with size. Is this a pustule? Is this urticaria? Is this the scale, a crust, an erosion with an ulcer? Does the patient have petechia or purpura? Does the skin show any atrophy or any telangiectasia, which is telangiectasia is an abnormal dilation of red, blue, or purple superficial capillaries, arteries, or veins, typically localized just below the skin's surface. So we're going to go through each one. A macule, a patch, they're flat. You cannot palpate them. They're not raised or depressed. A macule by measurement is less than 5 millimeters. A patch is greater than 5 millimeters. A macule represents a color change. And examples of a macular are freckles, flat moles, tattoos, cafe au lait spots, which is what this patient has, or magnolian spots. A papule or a plaque is elevated. You can feel it. It's palpable. Papular is less than 5 millimeters, and a plaque is greater than 5 millimeters. Examples are moles, warts, acne, skin cancer. And plaques are elevated lesions larger than 5 millimeters in diameter. They are like papules. They may take on a variety of shapes. A plaque is often a closed grouping of multiple papulars, such as seen in seborrheic dermatitis or psoriasis. A nodule is a firm papule, has more substance to it, as you can see, extended into the dermis or subcutaneous tissue. Examples are lipomas, which are fat pads, cysts, dermatofibromas, which is basically a benign, chiefly fibroblastic nodule of the skin, found especially on the extremities of adults. A vesicle or a bulla is fluid-filled, it's clear, it can be pus-filled, it can be raised. The vesicle is less than 5 millimeters, a bulla is greater than 5 millimeters. Examples of vesicles are herpes or allergic contact dermatitis. Bullae are bites, burns, and bullous disease. And bullous disease is found in diabetics. It's a distinct, spontaneous, non-inflammatory blistering condition of the acnal skin, and this is very unique to patients with diabetes. A pustule is vesicles that contain pus. It's usually less than 5 millimeters in diameter. Examples are bacterial infections, acne, folliculitis, and pustular psoriasis. In the photo, you have on the top one, you have folliculitis, and then the bottom is acne. Urticaria is an edematous elevated lesion, lasts less than 24 hours, can be caused by temperature, pressure, or sunlight, also called wheals or hives. Examples are drug reactions, bites, and stings. This requires an evaluation. Hives requires an evaluation, especially if it's around the neck or face. Scale, piled up accumulation of epithelium or dead skin cells. Dry, white, flaky. Examples are psoriasis, seborrheic dermatitis, or tinea fungus. Crust signifies that there was a liquid that has now dried, and that's either dried cerumen, dried blood, dried pus. Results when something was wet and then becomes dry. And examples, this is a classic example of impetigo. Also examples are crust or contact dermatitis, trauma from scabs. Treatment of this is a kid, it looks like, with impetigo. Impetigo is very itchy. It starts with almost looks like insect bites, but they're very, very itchy, and then they have vesicles, and then they ooze, and then they dry. And some, like this patient right now would need to be treated with Keflex. Okay, if you have like one spot on the lower leg or the arm, then you can treat it with Bactrovan and Keflex 500 3 times a day for 7 to 10 days. This is very contagious. Impetigo is very, very contagious. Erosion, also open areas of skin. Erosion, loss of part or all of the epidermis. Ulcer, loss of all of the epidermis and at least part of the dermis. Examples are trauma, venous stasis, dermatitis, peripheral artery disease, and infection. You can see here, this is an erosion here on this first slide, and then this is chronic venous stasis dermatitis. Petechia or purpura, non-blanchable hemorrhage bleeding into the skin. And blanching of the skin occurs when the skin becomes white or pale in appearance. Blanching of the skin typically indicates a temporary obstruction of blood flow. If you press gently on an area of skin, it likely turns lighter before resuming its natural color. In dermatologists will always be testing whether this is a blanchable or a non-blanchable rash. And they use the glass test, and they'll use oftentimes a microscope slide, and they press glass against a blanching rash. They press glass against a blanching rash, and it disappears. You can no longer see it. That is considered a blanching rash. We press glass against it, and you can no longer see the rash. That's a blanchable rash. This is a non-blanchable rash. If you put glass on that, it would still be there. That's a non-blanchable hemorrhage rash. Okay? Examples are petechiae. This is petechiae. They pinpoint. Purpura is ecchymosis, larger area. Examples are platelet dysfunction, vasculitis, infection, and purpura is infection, trauma, or coagulopathy. Atrophy is thinning of the skin. Skin appears wrinkled, dry, looks like cigarette paper. Examples are chronic sun exposure, aging, long-term topical steroid use, or lupus are examples of what can cause atrophy of the skin. Telangiectasia is focus of small, permanently dilated blood vessels. It's often idiopathic. Examples are rosacea, long-term topical steroid use, or sun damage. Other important descriptive language are location, number, distribution, color, character, size, primary lesion, surface changes, secondary changes, and any additional features. So descriptors, specific anatomic location. Is the rash distributed on the palms or soles, arms, and legs? If you're calling into a dermatologist, they will always ask you, is the rash in the palmar aspects of the feet or the plantar aspects of the feet? Is the rash in the interdigious areas, which are interdigital triginous areas is a medical term used to define where two skin folds may touch each other. Examples are the axilla, the anogenital regions, the nares, the skin folds in the breast, and between digits. And they harbor large amounts of aerobic cocci bacteria, which are both parts of normal flora. Is the location on the sun-exposed areas? How many number of lesions are there? 1, 2, 3, few, many, innumerable, several, sheets of a rash or extensive rash. Distribution, is it photo-distributed, which means is it sun-exposed? Distribution typically relates to other lesions. You know, is the distribution as far as other lesions? How is that? We already talked about intratriginous areas. Scattered, is it scattered? Is it only the distribution of other lesions in flexural creases, which is skin where the joint flexes, and that occurs behind the knee or inside the elbow. Extensor surfaces are interior of the knee or posterior of the elbow. Acral are peripheral body parts. Examples are the limbs, the ears. And when they talk about discrete rash, we're talking about a rash in areas separated by normal skin. A rash can be widespread. Is the rash widespread? Is it symmetric? Is it grouped, clustered, or is the rash linear or discrete? And a discrete rash is areas separated by normal skin. Color is erythematous, red, pink, violaceous, purple, dusky, brown, blue, skin, flesh-colored tan. Brighter colors for a rash can mean more acute, as the color dulls as the rash ages. And the character, is the rash moist? Weepy, moist, looks allergic or infectious. That is classic for impetigo. Classic, and it's very infectious. Thick, lacinification. It's thick, right? That's a lacinified area that's been itchy, 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 itchy. Or is it edematous or erythematous? More descriptors. And also, character refers to texture of the rash: hard, soft, moist, or dry. Size, more descriptors. Measure and metric system. Difference between scale and crust. A scale is dry, dead skin. There was never anything wet in a scale, whereas crust is previously wet and now dried. When you measure, you want to measure always in millimeters or centimeters using the metric system. Know that 1 inch equals 2.54 centimeters, and a millimeter equals 10 millimeters equals 1 centimeter. Desquamating or desquamated is really, when we talk about surface changes, that's the peel off of forms of scales. Lots of scaling off of skin. Exfoliating, crusted, scaly, smooth. Shape. Is the shape of the lesion annular, which is circular, ring-shaped, and here's annular? Or is it targetoid? And this often can occur in herpes virus. It's usually in the palms and the soles of the feet. Must have 3 color changes in order to be targetoid. Okay, here you have dark red, light, and then even lighter in the center. Serpiginous rash, which is serpent-like. Cutaneous larva migraines, which occurs from an insect. Not usually in the U.S., but know that if you have a serpiginous rash, you might be dealing with an infectious disease from another country. Nummular is coin-shaped, example of nummular eczema. And follicular, which is distribution where the hair follicle is. Arcuate, which is curved like a bow, which I don't have a picture of, but know that that oftentimes is a term used. Secondary changes are secondary is everything the patient is doing to the rash. Changes from scratching, changes from treatment, excoriation, lacinification, and that's the process which the skin becomes hardened, leathery, or lacinified, usually as a result of chronic irritation or hemorrhagic crust from itching. Atopic dermatitis, another word for that is eczema, is a chronic skin condition with intense itching. Highlight that. Typical pattern of distribution. Is the flexors, the front and sides of neck, face, eyelid, forehead, wrists, dorsal feet, hands, and it can be generalized. The risk factors for someone with eczema is a personal history, family history of atopic disease. And atopic disease consists of asthma, allergic rhinitis, and atopic dermatitis. Those patients who live in a dry environment are at risk, and also emotional stress is a big risk factor for eczema. Signs and symptoms can be exudative, rough, red patches, papules and vesicles on erythematous base, can be chronic with lacinification and dry fissuring areas in the face, neck, upper trunk, antecubital, and popliteal fossa. Areas can be dry, leathery, and lacinified from irritation, and patients always have intense pruritus. You have to have itch before you call it eczema. Real important key there. General skin care and prevention. Local therapy is soothing soaks or dressings. Chronic lacinified lesions, you want to use high potency topical steroids. If they don't work, you most likely will go to tar preparations if they're unresponsive to therapy, to steroids. And then immunomodulators is also an option. It's not first line, know that. It is not first line because it can cause cancer. Elidel is an example of an immunomodulator, and tacrolimus is also another modulator. Again, it's not first line, it's short-term treatment, and it has a black box warning for cancer. Oral histamines oftentimes are used for the itch, to relieve itch more effectively. You can use Benadryl or Atarax. A lot of times Atarax is used. The dermatologists love Atarax. Some of the keys to reducing or eliminating factors that promote dryness and increase desire to scratch are: you want to keep the environment slightly cool and well humidified. You want to avoid frequent hand washing. You want to wear plastic gloves for wet work. You want to keep skin well hydrated by daily baths, no warmer than 90 degrees, and soak for 10 minutes. Always use a mild cleansing bar such as Dove, Eucerin, bases to watch axilla and groin area, and use plain water on other areas of body. Avoid over-aggressive use of washcloth, which can exfoliate and remove the stratum corneum. Skin should be patted down after bath, and moisturizer is applied immediately to still moist skin. You want to tell patients to wear loose-fitting 100% cotton clothing, avoid wool, use fragrance-free laundry detergent, recognize that emotional stress can worsen but does not cause the disorder. Systemic infection, these patients might require oral prednisone, oral antihistamines, or phototherapy. Topical steroids, ointment usually necessary to alleviate inflammation during an acute flare. You want to apply thinly 2 times a day until controlled for 14 days in adult. Recommendation with mild to moderate eczema is triamcinolone ointment, 0.1%. Failure to respond with topical steroid therapy necessitates referral to dermatologists. May use steroid cream instead of ointment. Ointment leaves a greasy feeling that patients may dislike. Ointment provides the most potent concentration and has occlusive action. So ointment leaves a greasy feeling that patients dislike. Ointment provides the most potent concentration and has occlusive action. Creams require more frequent application. Allergic contact dermatitis, acute or chronic dermatitis from direct contact and subsequent irritation. Risk factors: exposure to irritant, prior sensitization to allergens. Irritants can be soap, detergents, or organic solvents. Organic solvents include dry cleaning, paint thinner, nail polish remover, or glue. True contact allergens are considered to be poison ivy, poison oak. Topical irritants include antimicrobials, adhesive tape, and latex. Poison ivy is the most classic example. Nickel is the most common cause worldwide. And you know, I inherited my mother's wedding band and has like 3 different types of gold on the ring, but I think it has nickel in it. And I'm not sure, but I'll wear the ring, and I've never had any type of contact dermatitis, only to poison ivy. But when I have this new ring on, I can get intense itching with blistering, and I just have to take the ring off for a while, and then it goes away. I've never taken anything, but what I have done is taken the ring off and moisturized crazy my hand. Allergic contact dermatitis, you have intense pruritus, which, just like I said, scaling, erythema, edema. Tiny vesicles or bullae can occur. Thickened skin, weepy, encrusted lesions in chronic phase. Diagnostic studies, clinical presentation, patch testing after episode is resolved. And patch testing is most likely done by a dermatologist or an allergist. It's a way of identifying whether a substance that comes in contact with the skin is causing that inflammation of the skin. Treatment, you want to first identify the irritant and then prevent any exposure. Barrier creams with high exposure risk, local involvement, compresses, potent topical steroids, widespread involvement. Really require a prednisone taper. And remember, the prednisone taper has to be like 2 weeks. I mean, that's really, really important. That's a board question. But also, you're going to have patients that you're going to treat with this. You can't treat them with 60 days of steroids. 60 milligrams of steroids for 3 days. They need to be on 60 milligrams for 3 days and then taper down 10 milligrams every 2 days. So 60 milligrams for 3 days, 50 for 2, 40 for 2, 30 for 2, 20 for 2, and 10 for 2. If you have to do 60 for 3 days and then 50 for 3 days and then 40 for 2 for the rest for the 2 other days, something like that in those terms. But there has to be like almost 2 weeks in order to eradicate contact dermatitis. Treatment, psoriasis, common, benign, acute, or chronic skin disease based on genetic disposition. You have reduced epidural turnover time. Occurs in 1 to 2% of the population. The etiology is infection, weather-related factors, medications, or psychogenic factors. What does psychogenic factors mean? There is a correlation between stress, anxiety that causes psoriasis. Sorry. Normal skin cycle is 12 days with psoriasis, and it is shortened to 1.5 days, okay, in patients with psoriasis. This means that in a patient, you will see excess dry, scaly skin because it's rapidly going through the skin cycle. Signs and symptoms may be asymptomatic, occasional itchiness, sharply defined red plaques with characteristic silvery scales. You can have pitting of the nail beds. You have Osbert sign, which is a droplet of blood when scales are removed. Common sites are the scalp, elbows, knees, palms, and soles of the feet. Psoriasis, limited involvement, less than 20% of the body. You can use topical steroids, mild to high potency. You can also use tar preparation, and those are creams that contain tar, and that usually takes 6 to 12 weeks before a patient sees improvement. Generalized involvement is greater than 20% of the body. You want to refer to a dermatologist. These patients are going to have systemic treatments, which include biologic treatments, it also can include UVB light 3 times a week, with PUVA for those who fail UVB light. Systemic treatment, when we talk about systemic treatment, that can be Humira or Enbrel, which are very common to use for psoriasis that have failed topical steroids, tar preparation, and that is also an option. PUVA is psoralen plus UVB, and psoralen is a photosensitizer, and it's in PO form, okay? When you take this, you make the patient more susceptible to UV radiation. Psoralen is taken by mouth 1.5 to 2 hours before therapy. This increases the risk of squamous cell cancer, so it is not used as first-line treatment. And biological treatment is considered Humira or Enbrel. And psoralen is a photosensitizer. Nail psoriasis, good pictures of nail psoriasis. Dermatomyositis, sorry guys. Classified by location. This is basically tinea, fungal infection. You can have tinea capitis, which is ringworm of the scalp. You can have tinea corporis, which is ringworm of the body. You have tinea cruis, which is jock itch, ringworm of the groin. Tinea pedis is athlete's foot. Tinea manuum is ringworm of the hand. Tinea varicebola, which is pityriasis varicella. And tinea unguium, which is onychomycosis, which is fungal infection of the nails. Diagnostic testing is, you can look under the microscope. Dermatologists do this all the time. You use potassium hydroxide in the microscope, which is like a liquid essential for the office-based diagnosis of tinea infections. This technique directly shows hyphae and confirms infection. You can also use fungal culture or Woods lamp. However, if your patient has been treated at home with over-the-counter antifungals, on the slide, and you look under the slide with KOH, potassium hydroxide, you may not see hyphae on slide. But if you send for a fungal culture, it will be positive, even if patient is treating it already. Dermatophyte slide, you'll see a hyphae, which is translucent, and blanching, which is a good picture of the slide there. Tinea pedis, which is athlete's foot. It's an infection of the feet. It's characterized by erythema, scaling, and maceration. Males greater than females. Predisposing factors: hot, humid weather, excessive sweating. Once infected, patient becomes a carrier and is more susceptible to reoccurrence. Maceration is, you can see the picture where it's white and soggy. Usually, athlete's foot starts with the 4th and 5th toes. Webs become dry, scaly, and fissured, and itching worse when shoes and socks are removed. I just had a patient this weekend that I saw who had fissured, who had athlete's foot but developed an impressive cellulitis due to the opening of the skin. So it almost looked like the patient, because he had calluses on the plantar aspects of the foot, it looked like it might have been an abscess. It wasn't. I ultrasounded. It wasn't an abscess, but he had an impressive cellulitis and treated with Bactrim and Keflex. But it started as a fungal infection from an opening of a fissure in his toe. Tinea pedis, again, is intradigital type, dry scaling, paling, fissuring of the toe webs. You can get chronic hyperkeratotic or hypertrophy of the skin. You can get chronic plantar erythema with slight scaling to diffuse hyperkeratosis. This type is also called moccasin tinea pedis after its moccasin-like distribution, which is this example of that. Tinea pedis, you can use gels, quick drying between toes. Or creams for chronic dry moccasin changes. You can use Lotrimin, tolnafenate, Desinex, Meconazole. There are 2 different types of creams that you can use. Oral, you can use Lamisil, Itraconazole, or Fluconazole. Oral treatment is necessary if the infection is in the nails. If in toenails, you cannot get rid of it without orals. So if in toenails, you cannot get rid of it without orals. Even with pills, it may not go away. Lamisil is what we normally use, but it has a lot of potential side effects to the liver, so you have to explain that to the patient. It also interacts with a lot of medications. You use Lamisil 250 milligrams a day for 4 to 6 weeks. It has a cure rate of 71 to 94%. Toenails, you have to take this for 3 months course. Fingernails, 6 weeks. And remember, you must clear athlete's foot in order to treat the nail fungus. So that has to be cleared in order to treat it. If you don't treat the nail fungus, you're never going to get rid of the toenails or the fingernails if you can't treat the toenail fungus. You want to check LFTs before you start oral treatment and half the way through. You want to apply Vicks Vapor Rub. Also is used. It's a non-toxic remedy, and it's shown to eradicate tinea pedis as well. Prevention, you want to tell patients to wear wider shoes, use antifungal powder to absorb moisture, change wet, sweaty socks, apply burrow soaks, which is a mixture that dries out wet, weepy skin, and you can use it for 10 minutes a day, and also have patients use Gold Bond in their shoes. Tinea unguium, which is also called onychomycosis, which is the fungal infection of the nail. It's the most common disease of the nails. Signs and symptoms: the nail plate can be thickened, yellow, or cloudy appearing. The nails can be rough and crumbly, or can separate from the nail bed. Tinea unguium, that you treat with systemic therapy, Lamisil 250 milligrams every day for 6 weeks for the fingernails and 12 weeks if toenails. You can also treat with Sporanox, which is 100 milligrams PO BID, or 200 milligrams PO daily for 8 weeks if they're just fingernails, and 12 weeks if it's toenails. You can also do pulse regimen, which is 200 milligrams PO BID for 1 week per month. Okay, so 200 milligrams daily, twice a day for 1 week. For 1 month, you treat in 1 week, and then for 2 months or 3 months in the toenails. Fluconazole, 150 to 300 milligrams PO every week, times 6 to 12 months until complete normal nail growth. Topical therapy medications are not curative. Penlac nail lacquer applied topically BID for 48 weeks. Tinea corpus is dermaphyte infection of the trunk, legs, arms, and neck, excludes the feet, hands, and groin. Inflammatory annular plaques, classic ringworm infection, causes transition from other parts of the body. Contact with animals or contaminated soil is the cause or the reason how patients get it. Duration is weeks to months to years. Signs and symptoms are ring-like lesions, small to large scaling, sharply marginated plaque, red elevated border with central clearing, produces annular configuration with concentric rings, single or multiple lesions. Topical antifungal cream twice daily for at least 4 weeks. Concomitant use with mild corticosteroids, itch and inflammation. Barrow's solution if weeping. Severe cases, you want to use a short course of systemic antifungal, triconazole, or terbinafine, Lamisil, which you might need to use. An example of impressive ringworm. So it starts off this very flat area. And tinea capis, which any tinea that's on a flat papule like that, you need to treat with oral antifungals. You cannot treat with creams on the head, or you will get what is called a crater, and it looks like something like a alien that's growing out of the head. I don't know if anyone's ever seen a crater on the head. It's the absolute most nastiest thing. So one of the biggest things, and that's the board question, anything on the head, tinea capis, is treated with oral agents only. Only. Creams will not help ringworm of the head. Tinea varicella, common cutaneous fungal infection caused by fungus Pittosporum ovra, which is a type of yeast which is normally found on human skin. Most common in adolescents and young adult males, and is associated with climates. Pittosporum is called. So, oval to round, hypopigmented or hyperpigmented macules, which you can see, typically located on the back, chest, arms, neck, or face. What you have is tan to pink spots, or very faint on light-colored skin, and light or dark spots on dark skin. The fungus prevents the skin from tanning. Treatment is antifungal cream, ketoconazole, 1% or 2% cream twice a day for 1 month. You have them wash with 2.5% shampoo daily for 1 week. Then they can go to over-the-counter dandruff shampoo applied to the skin for 10 minutes each day in the shower. May also help treat the lesions. Then daily for 7 days. Then one time a week for 1 month, and then monthly. Or you can do ketoconazole shampoo weekly. Candidiasis is yeast-like superficial fungal infection, occurs on moist cutaneous and mucosa areas. Risk factors are those who are immunocompromised, diabetics, broad-spectrum antibiotic use, obesity with redundant skin folds, occlusive clothing, or hyperhidrosis, which is a condition where patients sweats uncontrollably. Signs and symptoms are pruritus, superficial beefy red appearance, white curd-like discharge, peripheral satellite vesicular border, occurs in skin folds, anal, genital region, or axilla. Diagnostic studies are not typically indicated. Hyphae might be visible with KOH preparation, but not always. Treatment, you want to treat the affected areas, should keep dry and open to area. You can use topical antifungals like nystatin, switch and swallow. Or you can use trosses, which is oral clometrazole, or systemic antifungal agents. Anal genital involvement, topical antivaginal antifungal agents you may use, or you can use oral fluconazole 150 milligrams PO times 1, or itraconazole 200 milligrams BID for 2 to 4 weeks for refractory cases. Acne vulgaris is a skin disorder characterized by comedones, papules, or pustules. May be exacerbated by steroids and anticonvulsants. Food has not been demonstrated to be a contributing factor. Etiology and demographics, most common skin condition. Unknown etiology, more common and severe in males, more common in women between the ages of 25 and 44. Risk factors are genetic disposition, male, anticonvulsants, or steroid use. Signs and symptoms, comedones are hallmark. You can have closed comedones, which are tiny, flesh-colored, non-inflamed bumps, or open comedones, which are blackheads. Papules, pustules, or cysts on face or upper trunk. Perioral dermatitis, lesions on the chin and around the mouth, most common in women ages 30 to 50. They can be depressed and cause hypertrophic scarring. Treatment for mild acne are topical antibiotics applied during the day, such as clindamycin or erythromycin. Also, benzoyl peroxide applied during the day, which is also cream. Topical retinoids, tretinoin, or adapalene is also a different retinoid that you can use as well. Improvement may occur over months. You got to tell crazy mothers that are crazy that the kids have acne that it's going to take months to actually resolve. Other antibiotics that can be used are tetracycline, doxycycline, and minocycline, and know that doxycycline can be used for acne, but you better be very careful if you prescribe this during the summer. It's also used for Lyme disease, and you can get a severe burn from the sun. So FYI, you have to do teaching. If this kid is going to camp, this is not, they should be coming off of it if they're going to camp. Moderate acne, oral antibiotics added to mild acne regime. Minocycline 500 to 1,000 milligrams BID. Doxycycline is 50 to 100 milligrams BID. Make sure you tell patient about sun and taper as acne lessens. Females oftentimes can go on oral contraceptives with estrogen that is combined with progesterone. Severe acne, you want to refer to a dermatologist. The above recommendations in the previous slides were for mild and moderate acne. Accutane is indicated for cystic or glomate acne or refractory acne. Note that Accutane is teratogen. It's teratogen, meaning it can cause malformation of the embryo. So patients, you have to make sure if you are in a practice that prescribes this, there's a whole protocol for this, and you have to make sure that they are not pregnant when you prescribe this. Monitor lipids, ALT, AST prior to therapy. It can cause serious side effects, such as neutropenia. It also can cause serious reactions like depression and violent behavior and suicide attempts. Rosacea. The etiology is common chronic inflammatory acne disorder of the face, increased reactivity of capillaries leading to flushing and telangiectasia. It often occurs in females between the ages of 30 and 50, and also in fair-skinned individuals. Acneiform is similar to acne in appearance. It's not acne, if you will. So common chronic inflammatory acneiform is similar to acne in appearance. The triggers consist of hot liquids, spicy foods, alcohol, sun exposure, vasodilators, stress, and anxiety. Signs and symptoms, you see symmetrical localization on the face, you see flushing, tiny papules, you can have papules with small pustules. Again, you have telangiectasia, you have chronic blepharitis, conjunctivitis, and episcleritis, which is often benign and self-limiting inflammatory disease affecting the eye, which if a patient has episcleritis, they really should be seen by an ophthalmologist on an annual basis. Rhinophyma, which is a nodule swelling congestion of the nose in advanced stages of rosacea. Blepharophyma is chronic swelling of the eyelids, and otophyma, which is like cauliflower-like swelling of one or both ears, and nidophyma, which is swelling of the chin. Treatment, you want to avoid triggers. Topical, you can give metronidazole gel or cream. Which is Flagyl. Topical antibiotics can be used with rosacea. And if they don't work, you can use systemic, which is minocycline or doxycycline. Again, you have to do a lot of teaching in regards to making sure patients stay out of the sun, because they can have, if they're in the sun and they're on this, they can have major reactions to the sun that causes second-degree burns. Patients can have retinoic acid on this treatment as well. Surgery for erythema, also laser surgery for telangiectasia, which you see often, a lot of patients getting that. And erythema, again, is a descriptive term for large, bulbous, ruddy appearance of the nose caused by granulomatosis infiltration in the nose, and that is commonly due to untreated rosacea. Herpes zoster are acute vesicular eruption, results of the varicella zoster virus. It's contracted in childhood as chickenpox. It lies dormant in nerve ganglion, occurs only once in overwhelming majority of patients. Risk factors for developing shingles are advancing age, immunosuppression, and trauma to sensory ganglia. Pain, signs and symptoms, pain along dermatonal pathway occurs 48 hours before eruption of lesions. Root vesicles on erythematous base. Unilateral distribution. Typically does not cross the midline, but may in immunosuppressed patients. Vesicles erupt and crust over a period of 10 to 14 days. Patients often have regional lymphadenopathy. Diagnostic study usually diagnosed clinically with a zinc smear. Also, patients can be tested for varicella zoster virus antibodies or viral culture of lesion. So in the ER, this is really a clinical diagnosis made based on how the patient presents. We won't do any of these in urgent care or in an ED, but we'll leave it up to primary care doctor to do this. Treatment, you want to reduce post-herpetic neuralgia. You want to treat with acyclovir 800 milligrams 5 times a day, Femvir 500 milligrams TID, or Valtrex 1 gram TID. Ophthalmology consult for ocular involvement. If you have, oftentimes you'll have a patient with Hutchinson's sign. They'll start on the nose, and before you know it, goes to the eye. So Hutchinson's sign, I will have them go see an ophthalmologist, because you can just have a lesion on the nose and on the ear and nothing near the eye yet. I would go ahead and just send them to ophthalmology. Post-herpetic neuralgia, you want to treat with capsaicin ointment, which is a numbing ointment, or topical lidocaine, a tricyclic antidepressant for post-herpetic neuralgia, some anticonvulsants to help with post-herpetic neuralgia or regional nerve block. Common self-limiting inflammatory skin disorders, pityriasis, rosacea. The etiology is viral, more common in women, more common in young adults, and more prominent in the spring and fall. Signs and symptoms, you have a Herald patch, which is the primary lesion. It's usually salmon red. Initial lesion precedes eruption by 1 to 2 weeks. Initial lesion is larger than subsequent lesions. It's oval, slightly raised, fawn-colored, scattered secondary lesions, and you have Christmas tree distribution, trunk and proximal arms and legs, and patients present with mild pruritus. Diagnostics, Always order an RPR, as syphilis can mimic this disorder. Treatment: spontaneously remits in 6 weeks without therapy. Topical steroids for pruritus, prednisone for severe pruritus, and UVB phototherapy or natural sunlight exposure for residual hyperpigmentation. That's a Christmas tree distribution, and that's a Herald patch. Pediculosis capitis, this is lice, local infestation, sucking lice that lay their eggs on hair shafts, feeds on the scalp and neck, can crawl up to 23 centimeters a day, lay nits within 1 to 2 millimeters of scalp. Young lice hatch within 1 week, maturing to adult over 1 week period, can lay 50 to 150 ova during a 16-day lifetime, and can survive 55 hours off the scalp. Louse infestation, which is a small wingless parasitic insect that lives on the skin of mammals and birds. Sucking lice that lay eggs on the hair shafts. Transmission, it occurs with shared hats, brushes, helmets, combs, head-to-head contact. It's epidemic in schools and classrooms. You want to avoid contact with contaminated items. No knit policy for school. You're going to give medicines that kill the pediculosis. Permethrin is an option. Permethrin-based products, lindane, Malathion, which is an anti-parasitic medications, or mechanical removal, which they do with olive oil, and they spend hours getting rid of the lice, and they're cleared for school. And then they'll come back and see them the next day. Looks like $350. Scabies, infestation by the mite Saprophyte scabia, spread by skin-to-skin contact. You have generalized intractable pruritus within 1 month after exposure and continues 1 to 2 weeks after treatment. Mites burrow, tunnel into epidermis shortly after contact, deposit feces in tunnels. Female lay eggs in tunnels, burrows 2 to 3 millimeters a day. Females live 4 to 6 weeks, laying 40 to 50 eggs, and eggs hatch after 72 to 96 hours. Treatment: treat close contact at the same time. Apply to all skin sites. Permethrin 5% cream you want to apply to all areas from neck down. Wash off after 8 to 12 hours. Lydane 1% lotion or cream. Apply thin layer to body from neck down. Wash off after 8 hours. Erythema multiforme, reaction pattern of blood vessels in the dermis, characteristic erythematous iris-shaped papular and vesicular bulbous target-like lesions. Involves the extremities, palms, and soles, and mucous membranes. It can be a reaction to drugs, an infection, or it can be idiopathic and greater than 50%. Treat the underlying cause. Prompt withdrawal or possible cause of drugs. Symptomatic treatment for mild cases. Oral lesions, oral rinsing with warm saline or solution of Benadryl, xylocaine, and kaopectate for symptomatic relief. Severe cases, you're going to put them on steroids. You are going to do meticulous wound care if there's any opening areas. Seborrheic keratosis is a benign epithelial tumor, frequent in elderly, proliferation of keratinocytes or melanocytes. Most common benign tumor in the elderly, infrequently associated with underlying malignancy. Signs and symptoms: you have plaques ranging in size from 3 millimeters to 20, variable color, beige, brown, black. You have an irregular surface. Borders may be irregular, plaque with warty surface, greasy, stuck-on appearance. Treatment: none required. Light electrocautery, chirosurgery with liquid nitrogen. Actinic keratosis are small patches that appear on sun-exposed skin, more common in fair-skinned males, considered pre-malignant. Signs and symptoms are small patches less than 10 millimeters. Color is variable, flesh-colored to hyperpigmented. You have adherent hyperkeratotic scale, coarse-like texture. Treatment, you want to avoid UVA or UVB rays. Topical therapy would include cryosurgery, 5-FU cream, imiquimod, which is an immune response modifier. And UVA rays, they penetrate deep into the dermis, UVA rays, the skin's thickest layer. And this unprotected exposure can lead to premature skin aging and wrinkling, where UVB rays will usually burn the superficial layers of the skin. Photodynamic therapy is a treatment that uses special drugs called photosensitizing agents along with light to kill cancer cells. And systemic therapy consists of Accutane that can help akinetic keratosis. Basal cell carcinoma is a slow-growing carcinoma. It's a papule or nodule with central umbilication, which progresses to significant ulceration. No risk of metastasis. It's the most common type of skin cancer and occurs most in young and middle-aged adults. It occurs more in males than females. Risk factors: excess sun exposure, fair skin with poor tanning ability, previous basal cell cancer. Signs and symptoms: they're slow growing, 2 centimeters over a period of years. They're waxy, pearly appearance with translucent quality. They're brown or gray pigment. You can see visible telangiectasia with basal cell carcinoma, most common on the face or other sun-exposed areas. Diagnostic studies are shaved or punched biopsies. Treatment is excision, a curettage or electrodesiccation surgical procedure to remove the skin lesion that dermatologists will do. Radiotherapy. These patients need to be followed up at regular intervals for 5 years to assess for reoccurrence, and you need to teach them that they need to avoid sun exposure. Squamous cell carcinoma is skin malignancy that occurs on sun-exposed areas, may arise out of actinic keratosis, develops over a few months. 5% potential for metastasis. Second most common type of skin cancer, most common in males. Age distribution typically greater at the age of 55 where this occurs. Risk factors are fair skin with poor tanning ability, history of sun exposure, tobacco use, and radiation exposure. Signs and symptoms develop quickly over months. Small red nodule, papule, or plaque. Progress to induration. Thick, adherent keratotic scale. Honey-colored exudate, and may be eroded, crusted, or ulcerated. Diagnostic studies: suspicious lesions should be biopsied. You want to excise the lesion. You can treat with electrodesiccation or curettage. You can treat with 5-FU or methotrexate for keratoacanthomas. So intralesional 5-FU, which is chemo, or methotrexate for keratoacanthomas. Malignant melanoma, less common skin malignancy, most deadly form of skin malignancy, high risk for metastasis, lymph node involvement at the time of diagnosis, 30% in 5 years, 5-year survival rate, and distant metastasis less than 10% in 5-year survival rate. Basically what you have is proliferating malignant melanocytes. Risk factors are family history, excessive sun exposure, severe sunburn at an early age. Outdoor occupations are at risk for malignant melanoma. Fair-skinned, And how the signs and symptoms, these lesions have an asymmetric border. Border is irregular. The lesion is asymmetric. The color is mottled, could be brown, black, gray, or pink. The diameter is larger than 6 millimeters, and elevation is almost always present. We need to biopsy any suspicious malignant melanoma, and it needs to include all the margins. Tumor thickness is the single most useful prognostic indicator. Treatment, immediate consultation, excision to include 1 to 3 centimeter margin, and a sentinel lymph node biopsy is needed. That's it, guys. I will say that I posted on there the American Academy of Dermatologists. Under education in that website, they have a bunch of quizzes that are under basic dermatology, which will be very, very helpful for you for studying for the final. If you have any questions or any concerns, please let me know. And that's the end of this lecture.